Hello everyone, welcome back to my channel. I'm Dr. Ushna Naveed from the AMC Smart Prep platform. This is the code which you can scan to join the WhatsApp group for your preparation. I offer 2 months paid course which is covering all the theory for required for AMC Smart Prep. And this is according to the updated guidelines. For AMC, you have to follow the therapeutic guidelines, your RACGP guidelines, SA Health guideline, RCH guidelines. So these guidelines sometimes you find so disturbing and sometimes it's very difficult to follow all the guidelines. So all you need to know is to remember the theory which I will provide you in a paid sessions, which is in about 2 months durations. For getting the details of whatever the paid session is, you can join the WhatsApp group and the Telegram group. The link will be provided in the description box. So without wasting the time, the first topic is basically Croup. Okay, Croup is a very, very important topic for your exam. Pediatric topic, respiratory topic, and with respect to your respiratory portion of your pediatric portion. Croup is also known as laryngotracheobronchitis. This second name is a very important thing, because whenever you see the word itis in any question or any term, remember itis mean inflammation. So laryngotracheobronchitis, that means there is an inflammation of the larynx, there is inflammation of the trachea, and there is going to be inflammation of the bronchus in your child. Okay, this is a disorder of your pediatric population. So basically upper respiratory pathway that is going to be inflamed, that is going to be swollen, that is the main presenting feature. Then very important thing is that what is the age of distribution that is the Croup patient is having. Remember, peds is all about remembering the duration, remembering the age predisposition. So Croup is very common in the 6 months to 6 years of age. It is caused by the parainfluenza virus most of the time, but yeah, COVID virus can also cause cold such kind of symptom. But in MCQ, you need to be very focused about the causative organism. This is very favorite for your exam. So parainfluenza virus, that is the causative organism that is causing your Croup. Now Croup is inflammation. Whenever you have inflammation, there is going to be cough, but cough is not a normal cough, not a viral cough like normally most of the people having. This cough has a very, very important feature, that is diagnostic criteria for the Group, that is known as barking cough. Okay, so sound of the dog like feeling. So barking cough, very severe, very bad cough is basically your presenting feature of the cough. Plus cough, you can have another features which is not hard and fast, which is not 100% of the cases, but yeah, you can have stridor in the patients as well. So these two features are very important in the Groups: barking cough, stridor, young child 6 months to 6 years of age, caused by the parainfluenza virus. Think of Group. Diagnosis is very favorite for your exam, causative organism is very favorite for your exam, so you should be very clear what are the symptoms of your Group patients. This is basically inflammation of upper respiratory tract infection, which is your larynx, trachea, and bronchi, as the name suggesting, laryngotracheobronchitis, and it is triggered by the virus, which we have just covered, parainfluenza virus. This is so notorious for causing the Croup. Other than parainfluenza virus, you can have COVID-19 virus. The age is very specific, 6 9 to 6 years of age. Virus and night child. This is the lethal combination the Group is having. So symptoms are very, very worse at night. Children are very scared at the night. So yeah, symptoms are very worse at the night. Now the very important thing is that if you're suspecting Croup, then how should approach the patient of the Group? What should be the your management or assessment strategy? So this thing is a very important concept for your exam. This is not just the thing that the patient is having symptom and you start checking the patient and monitoring the oximetry and auscultating your chest and examining the throat. Group does not require any of these. This is a clinical diagnosis. You do not want to disturb that child. Okay, Group is a very you can say a barking cough. Just remember, like a dog is sitting in front of you. No, pardon, like child is not a dog, but yeah, if you see a dog in front of you, what would you do? You will not disturb that dog. Okay, let the thing happen whatever the dog is doing to you. So just remember, the barking cough, dog like cough, is having Croup. So you do not want to disturb the child at all. Okay, so the observation that is required, oximetry, blood pressure monitoring not required, throat examination not required. Many a times they give you an option that you have to do throat examination, you have to do pulse oximetry, you have to auscultate the chest. Nothing, no, nothing is your option. Just keep the child with the carer, with the sitting comfortably, not disturbing the child much, so that you are not basically disturbing the child because whenever you disturb the child, there is going to be increased work of breathing. What do you mean by increased work of breathing? This is again a very important question. Many a time you are not concerned that what is increased work of breathing. So increased work of breathing, remember, that means use of accessory muscles of respiration. The sternocleidomastoid is not very important, your intercostal muscles basically. That's why the patient is having intercostal recession, subcostal recession. So that means the patient is having increased work of breathing, and you do not want this in your child. Next comes the risk assessment of the group. This is a normal airway. See, very beautiful normal lumen of the airway, no congestion, no edema, no redness, nothing is there. But in group, what happens? There is so much inflammation going on. Due to that inflammation, your passage of the air is narrowed. Okay, so instead of having very beautiful passage, which is a circular passage, you are having inflamed, congested passage, and that is causing obstruction to your passage of air. So any previous history, any pre-existing narrowing factor, any disorder that is basically affecting your musculature, respiratory portion is your muscle. So anything that is disturbing your muscle can exacerbate the croup. Very important example for your exam is trisomy 21, Down syndrome, neuromuscular disorder, a very notorious feature. So trisomy is again your recall question. So you should note all these topics that are very important. Trisomy 21, parainfluenza virus, barking cough, increased work of breathing. These are very important points in your group patients. Then if a patient is a very young patient, less than 6 months of age, less than 3 months of age, then again this is a red flag sign. You have to be very serious for these patients. These are the clinical features. Barking cough, remember this cute dog, but this you do not want to disturb that dog. Stridor, plus minus, it can be there. Hoarse voice, because there is inflammation in the throat. You have associated wheezing can be there. Sometimes you can confuse this patient as asthma because the wheeze is there, but obviously asthma do not present with the barking cough. So the main important culprit that is helping you to reach the diagnosis is basically your barking cough. This is a very, very important sign which should not ignored. Then your patient can have increased work of breathing, fever can be there, but remember your croup patient is not very hemodynamically unstable. There is no sign of toxicity. The patient is absolutely fine. Clinically the lab parameters are normal. He is not having very severe symptom as like the second most important counterpart is that epiglottitis. So epiglottitis patient is very sick. Croup patient is not that much sick. Then that classify the patient according to severity: mild, moderate, severe. Now this classification is master for your exam, very, very important for your exam, high yield topic for your exam, because the management is entirely different. If you are classifying mild, the treatment is different, moderate, treatment is different. And in exam, you won't believe that in one attempt there was 3 questions of the group. In Feb 2026, there were 3 questions of the group: mild, moderate, severe, intensity, and the treatment was entirely different. So be particular when you are classifying the group patients. So mild, remember, when the patient is absolutely fine, well perfused, everything is normal. Moderate, again, he is appearance wise fine. But now, what is the difference between mild and moderate? The game changer is your stridor. This is the thing that is going to describe that the patient is having mild symptom or the patient is having moderate symptom. This is the defining criteria. So if your patient is having stridor that is intermittent or none at all, okay, the patient is not having stridor, only when the child is very active the child presents with your stridor. This is known as mild case. Okay, mild none, or very active child is having stridor. If you compare this mild with the moderate one, the patient is having intermittent stridor at rest. That means the patient is having now moderate symptom. But when you move to the severe symptom, now the patient is having persistent stridor. So these words are very, very important for your exam. These are basically your recall words. Okay, so you should be very particular that when you are describing the severity of the stridor, you are basically describing your mild, moderate, and severe category. So if the patient is having no symptom, this is mild. If the patient is having symptom that can be controlled, like intermittent symptom, this is moderate. And if the symptom is persistent, this is basically severe. Life threatening, you will be easily identified that the patient is silent, the patient is having drooling, there is so much, you can say, confused, drowsy patient. So anything that is basically causing deterioration of your normal appearance of the patient, this is life threatening condition. So you can easily identify. Hypoxia is again a very important parameter, because many a times group does not present with hypoxia until unless you are talking about mild and moderate one. Hypoxia is only the late sign in your severe group or the life-threatening group. So hypoxia is a very important thing, stridor is a very important thing, and any child that is presenting to you with a very confused state, that is basically your life-threatening group. So that's how you have to classify your patient of group. Why we are classifying the patient? Because the treatment is entirely different. For mild patient, you just have to observe, okay, nothing is required, just observe. If that is troublesome to the child, then you can consider, not mandatory, you can consider the dexamethasone, okay, dexamethasone or prednisone, just a one dose. If good response, the patient can be discharged to home. This is the mild category. But if you talk about moderate one, moderate, he needs treatment, definitively he needs treatment. So moderate kind of patient, he needs dexamethasone or prednisone. You do not need to remember doses for your exam, just remember the names, okay. So mild, consider discharging the patient, or you can give dexa or prednisone, not a mandatory one. Moderate, mandatory, definitively you have to give treatment. Severe disease, you have to nebulize. So that's how your treatment is entirely different, that what options you have to pick up from your different options that are given in the question. That if the severe category, then nebs is your answer. If moderate category, steroids is your answer. And the mild category, just observation is the answer. Then comes the life-threatening situation. So remember, life-threatening situation, you have to admit the patient in ICU. This is the first priority, that before giving anything, just admit the patient. That patient can deteriorate at any time. So admit the patient, then you give nebulized adrenaline in the form of like units, and along with that, maybe he requires oxygen because the patient is hypoxic and he needs dexamethasone. So that's how you are going to manage the patient of your severe, moderate, life-threatening patients of your asthma, the very important one. Then comes follow-up. So how you are going to follow up the patient? Discharge once the stridor is free at rest. So stridor at rest is never acceptable. The patient should be stridor free at rest to in order to be discharged. Observe for minimum of 3 duration. This duration is again very important before discharging the patient. You should be very clear that for 3 hours the patient is not having stridor at all. If there is a persistent overnight symptom, or the patient is limited access to medical care, like the patient of a rural setting or remote areas, so you can observe for more than 3 hours also. Or if the stridor is more than once during the episode, then again you have to observe for more than 3 hours. So these are the indications of prolonged observation. So you have to remember all these. Then other things are not very important, but yeah, you have to discharge patient whenever he is stridor free, and minimum of 3 hours observation is there. So this is all about the Croup patient, laryngotracheobronchitis. You need to remember. Let's practice a MCQ, that how much you have gathered the information. A 3-year-old boy, so age is very important, less 6 months to 6 years was the predisposing age. He is brought to emergency department at 2 a.m. So nighttime. Nighttime is alarming time. She reports that it has been unwell with a cold. Trigger factor is there. Over the last 4 days, he has worked with a distressing barking brassy cough. So this is a very important clue. Night symptom is there, barking cough is there, and the young child is there, 3 years of old child. He has no significant medical history, does not take any regular medication, up to date with immunization. So absolutely normal child, but he is having some kind of throat congestion. That is something alarming, that we are not happy with this. So throat congestion is there. Then the patient is having the problem that the on examination he appears distressed, the distressment is there, and this is audible then stridor, which resolves on its settles. At rest, the respiratory rate is 24. The respiratory rate is basically your 24 respiratory rate, and he is not using accessory muscle to breathe, and SpO2 is 96%. So he is not hypoxic. We are not concerned with the hypoxia. Which of the following is the most important management? So what you think the patient's severity is? Basically, the patient is having mild symptom, moderate symptom, or severe symptom. What you think? He is distressed, or he's having stridor, which resolves as he settles. That means in increased exacerbation, the patient is having stridor, but hypoxia is not there. Hypoxia is not there, that means we are not concerned with the life threatening or the severe one. So mostly we are dealing with the mild or moderate category patient. So if your patient is absolutely fine, or the patient is just having symptom that is not presenting with the intermittent stridor, so that is basically mild group. Okay, mild group. So mild group, remember we talked about mild group, you can discharge the patient, or you can just give dexamethasone. So answer is going to be your dexamethasone, oral dexamethasone in order for mild croup. So this is again the same symptom. You are not going to give humidified oxygen because he's not hypoxic. You are not going to give nebulized salbutamol because there was no point of salbutamol. This is not asthma. You are not going to give nebulized adrenaline because this is not a severe category. And azithromycin is not required because this is a viral infection. That's not bacterial infection. No need to give antibiotics. So that's how you are going to solve the patients of your group. Again, another question. A 3-year-old boy, he presents to emergency department with a 2-day history of barking cough. Again, your barking cough is there, and the intermittent stridor is also there. So intermittent word at rest. Okay, intermittent. This is pointing towards your which diagnosis? The moderate category one. He has no rigors or febrile episode. Parents report that he is irritable, reduced appetite, no significant medical history. On examination, he is anxious, harsh, inspiratory noise, that means stridor is there. Suprasternal intercostal retractions are there. So again, he's coming in the category of moderate one. He's not a mild category patient. Hypoxia is not there still. So this is not life-threatening. This is not severe. Which of the following is the most appropriate next line in adjuvant? So you remember whenever you are dealing with a mild to moderate category, both we are concerned with the oral dexamethasone. So this is a moderate category, but yeah, you have to give oral dexamethasone therapy, not the nebulized adrenaline. So this is basically the approach of the questions. So answer is going to be emergency situation. You have to give your oral dexamethasone. Again, the 4-year-old child is presented to emergency department by his parents, expressing concerns about the child's condition. The condition has been experiencing high fever, noisy breathing. Noisy breathing is your stridor. So the child is having your stridor. This is the main concern of the parents. A distinctive barking cough and the nasal discharge and the poor feeding for last 2 days. On examination, the child feels warm to touch, diaphoretic, visibly distressed, displaying irritability, and the persistent crying. A provisional diagnosis of croup is already made. He is recognized in urgency of presentation, and the medical team is prepared to conduct a thorough assessment, including the measurement of your patient's core temperature. Which of the following is the most appropriate method to measure the children's temperature in this setting? Now, this is very important question, that how you are going to monitor the temperature of the child. So remember our protocol, we do not want to disturb this little barky dog. So barking cough is basically the child is having so much distress, you do not want to disturb that child. Ideally, the best temperature is rectal temperature. Per rectum temperature is the best diagnostic value. But whenever you are putting anything in the rectum, the child is just crying so loudly, and he is so irritable. And anything putting in mouth, again he's so irritable. So what you are going to do, he is sitting in the mother's lap, and you just put a small thermometer in the axilla. That is going to be least disturbing to the child. Not in nasopharynx, not in oropharynx, not in forehead, infrared, because forehead, infrared do not give you ideal value, and not rectum. So axilla is the right site to monitor the temperature in the patient. Okay, so that's all about your croup diagnosis and croup management regarding MCQ. So this is very important topic. Many times you will see so many recalls regarding this croup topic. So second name is also very important, laryngotracheobronchitis. This is a very, very important topic you should remember. So that's all for today. If you want to join the Telegram group or the WhatsApp group, these are the link. You can use the link. Sorry that you cannot click this on the video, but yeah, you can type the link and join the Telegram or the WhatsApp group. I will add the link in the description box, so do check the description box to be updated with the links, or I will provide that links in the comment section as well. So you can join in by clicking the link in the comment section. And this is a code. Just scan the code to join the WhatsApp group. And if you want to join the paid sessions, this is basically a theory coverage in the whole of the theory required for AMC exam in about 2 months. Then yeah, you can contact these links, and whatever you need, you can just put your query into the comment section. I will reach out to you. Thank you so much.